because we are extremely privileged to have some distinguished and prominent guests to have a conversation with us at lunch today. So honorable ministers, country delegations, USAID and other development partner officials, MCHIP staff, and other representatives and colleagues in the global health community, welcome. My name is Megan Rhodes, and I'm the Deputy Chief of the Maternal and Child Health Division here at USAID. And I'm also a proud member of USAID's management team for the MCHIP program. I'm really honored today to host this luncheon session where we have the opportunity to hear from 4 prominent and distinguished guests about their country's experiences in tackling MDGs 4 and 5, the progress they've made to date, and their vision for the future to end preventable child and maternal deaths. Throughout this morning, we've had some really excellent presentations from countries around the world about efforts to improve quality of care and strengthen community health systems. These technical presentations and case studies have highlighted various pieces of the puzzle that have helped countries make progress towards MDGs 4 and 5, and to the extent that they've been successful, they'll continue to be important in the post-2015, post-MDG era. This afternoon, we're going to hear more about scaling up these puzzle pieces. In the bold vision of ending preventable child and maternal deaths, there are lots of interventions, strategies, and approaches that need to be well understood in order to continue to refine our approaches, innovate, and make progress. But what we all know is that there is absolutely no substitute for country-led plans and strong country leadership. Innovations, evidence-based interventions, and high-impact practices all need to be built on a foundation of local leadership in order to succeed in the long term. During today's lunch, we'll have the great honor to have ministers from Liberia, Nigeria, Rwanda, and Zambia up on the stage to share their experiences and wisdom and how they've helped take all of these technical pieces that we've been talking about and translate that into commitment, into actions, and into results. I'll be asking each of the ministers to reflect on things that have made the biggest difference in accelerating reductions in child and maternal mortality in their countries, and how they've worked to reach the most vulnerable, and their thoughts on what the future brings in their respective countries. This will very much be a conversation, and I've told the ministers that they should also feel free to just talk to each other and ask each other questions. We're really interested in hearing you all speak. Before we begin our conversation, I do just want to take a couple of moments and let me introduce our esteemed guests. So 3 over to my left is Honorable Minister Walter Gwenegali, Liberia's Minister of Health and Social Welfare.
That's you.
I'm going out of order, so maybe Dr. Gwenegali.
That's you.
Dr. G, as he's known to his friends and patients, earned a Doctor of Medicine degree from the University of Puerto Rico School of Medicine, and he also performed his surgical residency at Puerto Rico Medical Center. Dr. G returned to Liberia to the Phoebe Hospital and School of Nursing, which was actually scheduled to be closed due to lack of funding. But his surgical skills and his leadership have kept Phoebe Hospital and School of Nursing open and growing in healthcare services and education for more than 30 years. Through many difficult years of civil strife, Dr. G showed incredible courage and leadership, advocating for those most adversely affected by the war and helping to restore health services for Liberians. In 2006, Dr. Gwenegali became the Minister of Health. I believe he is the longest standing minister on the stage with us today. His leadership has been crucial in the post-war reconstruction in Liberia. And I understand that even on the weekends, even in his role as minister, he still returns to Phoebe Hospital and School of Nursing to perform surgeries. Welcome, Honorable Minister Gwenegali. So I'll next introduce the other young man on stage with us today, and then we'll move to the women. The Honorable Minister, Dr. Khaliro Al-Hassan, is Nigeria's Minister of State for Health. Minister Al-Hassan was born in Sokoto State in northwestern Nigeria. He completed his early schooling in Sokoto and is a medical doctor and did further specialization in tropical pediatrics at the University of Liverpool in the UK. He returned to Sokoto, where he served in the pediatrics department at the specialist hospital. He was named Chief Medical Director from 1996 to 2003. Since 2003, he has served as Director of Medical Service and Public Health for Sokoto for over a decade. We are privileged to have Minister Al-Hassan as a guest today, particularly since the federal system in Nigeria relies so heavily on strong leadership and stewardship from states, an area from which he can draw considerable experience. So welcome, Minister Al-Hassan.
Thank you.
I'd now like to introduce Honorable Minister Agnes Binawaho, who is the Minister of Health for the Republic of Rwanda. She practiced medicine in public hospitals before joining Rwanda's National AIDS Control Commission as Executive Secretary in 2002 and was the Permanent Secretary of Health from 2008 to 2011. She has a master's in pediatrics, specialized in emergency, neonatology, and the treatment of HIV/AIDS. She is chair of the Rwandan Pediatric Society, co-chaired the Millennium Development Goal Project Task Force on HIV/AIDS and access to essential medicines, and was the global co-chair of the Joint Learning Initiative on Children and HIV/AIDS. She's published in a wide range of topics, including human rights policies and implementation of health programs. She serves as a senior lecturer in the Department of the Global Health and Social Medicine at Harvard Medical School, and as clinical professor of pediatrics at the School of Medicine at Dartmouth College. We're most honored to welcome you, Honorable Minister Binawaho. And finally, I'd like to welcome Honorable Minister Emerine Kambashi, Zambia's Minister of Community Development, Mother and Child Health, a position she began recently in March of this year. Prior to this position, Minister Kambashi served as Minister of Local Government and Housing and Minister of Chiefs and Traditional Affairs. Minister Kambashi also served as Deputy Minister for the then Gender and Development Division within the Cabinet Office. She is a Member of Parliament for Luapula constituency in Luapula Province. And prior to her political career, the Honorable Minister was a civil servant in the Ministry of Agriculture. She holds a certificate in animal nutrition and a diploma in animal science. And we're truly privileged to have someone of her political clout and wide-ranging government experience join us today on stage. Welcome, Honorable Minister. So I'd like to begin with a question for each of you to really reflect on which health interventions in recent years have made the biggest difference in your respective countries to make progress towards MDGs 4 and 5. Do you see these same interventions as being important in the post-MDG era, or are there new interventions that we need to take on? If you could tell us a few things about what you think have made the biggest difference in maternal and child health in your country, we would love to learn from your experiences. Honorable Minister Gwenegali, may I start with you?
Well, yes. We came in, first I worked for a woman called Ellen Johnson Sirleaf, and she came in post-conflict. And when she came in with the country, all the system destroyed. You needed more to redo the health system, the education system. You needed to build the bridges, and then there was no funding. So for the MDG, the things that have worked for us was really trying to increase the number of trained people to do the work. So trained people means, in that respect, importantly was the midwives. We had lost many of our health workers during the war. They left the country. So to be able to address the maternal death issues, we had to increase the midwives. So there were actually 3 steps. One, to try to keep the few that we had by increasing their support financially. Then to go ahead and recruit as an emergency those that were available and could come by from working for international NGOs. And then to start training vigorously, because during the war, our midwifery schools were forced to close. So we had to reopen them and then start training more people. That was only one part of it. The second part is, even if you have the people, you have to have the supplies and for them to do the work. So and that costs money. And that's what the government did not have. But donor countries had goodwill towards Liberia. And so with their help and their support, we were able to put in place a funding system to protect their money through a pool fund system. First, we had to learn to be accountable, because people want to know what you will do with their money. And it's on both sides. So for our side, since we wanted the money, we had to put in place an accountability system to be able to account for the money, even though we were insisting that the donors themselves be accountable also, because some of them, based on how they give the money, that's not very accountable sometimes. So those 2 things had to. The third thing that helped is to accelerate the immunization program. So accelerating the immunization program helped to protect children. Then there were a few other things that we did, like teaching mothers how to protect their children by maybe exclusive breastfeeding for 6 months and those things. So those are some of the things that we have done.
Thank you so much, Dr. G. I think that's a great example of a mixture of both health systems approaches and a focus on high-impact interventions. And I'm wondering, Minister Al-Hassan, if you might add to that and tell us a little bit more about the experience in Nigeria.
Thank you very much. Nigeria being a federal entity, one of our major challenges was trying to get coordination into our health system. The federal government is, of course, there are state governments and the local government. So the key thing that we introduced was the restructuring of our primary health care, which was, responsibility of the local government. But we found there are a lot of need to improve what they have been doing. So restructuring of the primary health care was key to getting a lot of things done. First of all, we established the National Primary Health Care Board, who is the responsible organ for all the implementation of all programs targeted at the maternal and newborn child health. And this is being replicated at the state level, and with a lot of backing from the federal government. A policy was established to bring the establishment of this institution in the state government. So that was one of the important things that we did. And not only that, all the primary health care activities before were disjointed. The federal government is doing one thing, the state and the local government. So there were no proper coordination. So bringing all the activities under one roof, that was key to the success we have been recording. So bringing the primary health care under one roof, whereby there's a common basket, whereby everybody will put in his resources and it was accessible, and that is very important. Of course, we also realized, due to the nature of our country, it's so huge with large population, the human resource has become an issue, especially distribution. We realize that the distribution is all based in the capital cities, urban areas, to the detriment of the rural population. So there has been this active drive to redistribute all this human resource, especially that will ensure quality health care at the rural areas. These are some of the things that we did. Yeah.
Thank you. I might move us along to Minister Kambashi.
Okay.
If you have anything to add from Zambia.
Okay, thank you very much. For us as Zambia, I think the political will came from the president himself. He's very passionate. He had been a minister of health before, and immediately he took over office in 2011. He realigned the Ministry of Health and made sure that the primary health care is taken away from the Ministry of Health and brought it to the Ministry of Community Development, Mother and Child Health. Because it's a well-known fact that primary health care has also got to do with poverty. And in the Ministry of Community Development, Mother and Child Health, that's where we deal with the vulnerable people. When you look at our economies in Africa, at the moment, the economies are growing very big, but the gap between the richest and the poor is quite big also. And the president thought that if he brings primary health care to the poorest of the poor, it will narrow down the gap. And also it will give a bit of dignity to the poor. Because I know when I took office, I went into the village where I found a woman was refusing to go and give birth from the health center because she didn't have nappies and she didn't have a nice maternity dress to wear. And under my ministry, when we gave social cash transfer, it gave her dignity and it encouraged the women to go and give birth in the health centers. And I think that's what the government has done. And through using the structures of community development, mother and child health, the Ministry of Health is able to disperse the medication to the lowest structures of the community. And even the monitoring is done through the structures of community development. And what we are trying to do is also to integrate the efforts, of primary health care to make sure that at all the health posts that are being built, we bring in the issues of nutrition, we bring in the issue of monitoring growth, and also encouraging the women to come and give birth at these centers. And I think it's helping, and it has helped us a lot. And the issue of also distributing mosquito net has also reduced deaths in the children, and the testing, the rapid testing systems that have also been brought on board, because those children that are being found to be HIV positive are put on ARVs, and even the testing of the pregnant mothers also are preventing the transmission of HIV to the children. I think we have an integrated system at the moment, and we are working closely with the other ministries. I'm working very closely with the Ministry of Chiefs and Traditional Affairs, where we are campaigning, against early marriages, because early marriages also is a driver, of pushing up the maternal deaths. So the campaign against early marriages, against teenage pregnancies, through the Ministry of Chiefs, and we work together in the communities, is also helping us to reduce the number of deaths in our mothers.
Thank you so much. I'm going to turn now to Honorable Minister Binawaho. We've heard a little bit from the other ministers about focus on addressing human resource challenges, basic structure and work across the government, a focus on high-impact interventions. And I do know that Rwanda has made remarkable progress on MDGs 4 and 5. And could you share a bit about your experience with us?
What we have to say, we have to do all this because it's an holistic approach. So for human resource, we were also a country post-conflict. But not only that, we were a country without a nursing school and a country that produced only 100 doctors, MD, a year. So task shifting up to the local level, with having 3 community health workers in each village. Each village is 200 houses maximum. And there is 1 man and a woman that are doing ordinary care, malaria, HIV counseling, nutrition, pneumonia, they provide antibiotic by syndromic approach. So they treat 80% of the burden of disease at that level. They have a way to report each case using a cell phone. So we had to create this communication system. At the level of 100 village is a sector. And at the level of the sector, each sector we create a health center with nurses, where women are going for delivery, vaccination for children, etc. Primary care is given there. When it's not possible to treat, they are referred to the district hospital. Each district has a hospital. And there we find doctors. Surgery is done, C-section, etc. And when the district cannot give the care, there is the referral system. We have 8 referral hospitals in the country. So we have a pyramid of care that bring primary care where the people are living. And each level assures the quality of the lower level. So this is for the human resource and also infrastructure. The management system, the way we manage and we govern by cluster. We have 3 clusters, the social cluster, the governance cluster, and the economic cluster. The social cluster have inside all ministries that are dealing with social affairs, local government, agriculture, health, education, civil servant, gender, disaster, youth, culture, etc. We meet every month to discuss the policies and strategies of all the others. And we take decisions together. It's like you do, but we have a systematic way to do that, and we have to report every month to the Prime Minister. Okay. I cannot do a policy or a strategy in the health sector without my colleague having approving it. So it's mainstream everything, and it helps us to go faster. So for the governance is that. For the management, we have used IT extensively. In all corners of Rwanda, you can have access to internet. And we manage the health sector e-based, meaning the health information system, there is a report every month e-based. Community health workers, by SMS, they report. They also alert. That's how we can contain epidemic. But so for the pregnant woman and for maternal health and children, it has helped a lot. Because malaria, HIV, all the big killers are contained before the district. People get access to the IRVs, to the diagnostic, to the follow-up in their sector. And we have 5 ambulances by district. A community health worker call an ambulance with a rapid SMS, can ask advice with a rapid. So we have districts now that didn't experience the death of a woman over a year. Wow. Yeah.
That's
yeah.
good.
And we have reached the MDGs 4 in December 2013 and MDG 5 a few months before. So, but this is by proactively distribute health opportunities equitably across the country and assure that there is no more outcome. That means there is no part of the country that has more indicators, better indicators. And when it is the case, we go where the indicators are better to see what have we missed. And I have to, I'm pleased because my hero are the community health workers.
I would like to actually build on that and ask all of you. I think you've raised an important point. You're all in positions where you need to look out for the needs of the entire country and the entire system. But we know that you can't make real progress unless you bring the most vulnerable along with you. And so I'd like you all to reflect a little bit on, as you've approached these major challenges in building national health systems, and ensuring adequate health workers and that high impact interventions are implemented. How have you been challenged and how have you dealt with making sure that the most vulnerable in each of your countries is not left behind as you're striving for progress? Maybe I can start with Minister Al-Hassan and ask you to reflect on that.
Thank you very much. I think one of the major challenges that we have been confronting is to ensure the relief of the financial burden on the people, access to the programs, to limit the out-of-pocket expenses that the mothers and children usually incur while accessing healthcare. So that has been a major challenge. And one of the innovative ways we have devised to address it through a program known as a conditional cash transfer through the SureP program, whereby women are encouraged to go to facilities where they are being paid for their transportation, and of course, the medication and the services are free of charge. Most of them, the most poor income group, has found this very helpful, but they have been encouraged to go free, and they are being paid the transportation money, and the services are being offered to them free. This has greatly encouraged the attendance. Of course, the access to the service has been free of charge for them. And this is one area that we have been building up to ensure that more people are covered through our National Health Insurance Scheme. We're targeting presently to upscale to about 40%, whereby let's take the primary school children, and of course the pregnant mothers and children under 5 are being given free medical care across the country. And these are some of the programs we feel it will relieve the issue of the financial burden and the out-of-pocket expenses, and it has been very successful. Thank you.
Minister Kambashi, would you like to add in terms of how to, you touched a little bit before on reaching the most vulnerable,
Okay.
and particularly young girls, but.
Okay. I think as the government in Zambia, we are very keen, we are very passionate about the poor people. And, you know, it's the poor that fail to access these medical services. And with us introducing social cash transfer, which was introduced in 2003 as a pilot project, I think only about 4 districts were receiving social cash transfer. In 2014, we've upscaled that to about 50 districts. And we have reached about 1 million families, the poorest of the poor. We are talking about the aged. We are talking about the disabled and the child-headed homes. And these are the people who find it very difficult to go to the hospitals, maybe because of the way they are dressed, or maybe they can't, they don't have money for transport and other things. So we give them this little money that they can use for them to go. And we tie the social cash transfer to the primary health care. Like we are saying, that we encourage them that for them to continue receiving that, they have to give birth in a health center, or they have to take their children to school so that their lives are also improved. On the other hand, when we distribute things like the mosquito nets, those are accessed by the poorest of the poor. The supplementation of vitamin A, when we give them, we go into the rural areas, those places where we see that they don't have transport to move from one area to the other, and they're given those supplementation. And even for the antenatal, the people with money can afford to have iron supplements, you know, to go and get from wherever they want to get, or from the private clinics. But those that I can't afford, we go for them, we reach them, and we make sure that we encourage them to go and visit the health centers. So for us, that has done a lot of good to us, because the child deaths have gone down, because I think the government is reaching out to the poor. And the poor now have got a bit of dignity because of the social cash transfer. They can come to the community and mingle and share the problems. And we also tell them on how they can feed their children and all. So I think that's what we are doing as Zambia.
And Minister Binawaho, it sounded like part of your strategy for making sure the most vulnerable were served was really based on following the data and understanding coverage and understanding the services that are available in each area. Has that helped you to identify where the people most in need are and how to reach them?
It helps us to identify where there is the less uptake of care. Okay. It helps us to identify where there is the less uptake of vaccination. We have 90% of our kids vaccinated for 10 vaccines fully. So we try to, my job is to track the 10%. And for the 10%, 99% of them are vaccinated against with the BCG. But who and why they dropped out. So this is our job. But how we are sure that the most vulnerable are part of benefit? We have the cash transfer program that is based on community identification of the poor. As the majority of the population live in rural area and don't necessarily pay taxes, we have problem to identify what is the revenue of each and every one. So there is a categorization. We ask each village to categorize in 6 categories: the poor with no land, the poor with land, the mid-upper, the up, and the upper. So the 2 first categories, we have the health insurance paid by the government. And each point of care, normally everybody have to pay 10% of the care. This point of care is also paid for by the Mutuelle de Santé. And in Rwanda, there is an universal coverage of health insurance. People like us have one of the civil servants, take out of your salary, but people who are in the informal sector or rural area, agriculture, self-employed, have the community health insurance. And you pay according the identification your village have done about your socioeconomic status. And there are clear reasons. You have a house, you have a bike, you have a vehicle, an enterprise, etc. So you are put in the category, and the premium you pay is according your category across the country. And the 2 first category, the government pay for you.
Okay.
Now, there is also the fact that those 3 community health workers, the 2 and the woman that follow pregnancy and children under 1 year of age, are elected by the village. And in the village, poor or not, you have a voice. So if you want your right to be cared of, you can say, I vote for this one. And when the community health workers is elected, we have to train the community health workers. And when the community are not happy after time with one, they just say, we no longer want this one, we all vote for that one. And it's my job to send somebody there to train or to bring the community health workers, the new one, to be trained. But this is the system we have put in place: community participation and community identification of the socioeconomic status, and give them the same access to care through the health insurance.
Thank you. Minister Gwenigali, you've been minister for some time now, and at a very challenging time for Liberia in reconstruction. I imagine the issue of vulnerability for many people was quite large when you first began to try to reconstruct the health system. How has that changed, and how are you looking out for the most vulnerable now?
Well, during our Civil War, we really didn't have a Ministry of Health. We had so many international NGOs, different MSF and different groups were running the health system of the country. So when we got in, we found out that they were not charging anything at the facilities that they were, even though they had taken over government facilities, they were not charging fees. Because before the war, we had such thing as cost sharing, we have fee for service, and all of these things. The government was trying to make people pay something for their care. Yeah. Because even if a villager goes to a herbalist, the herbalist will charge something, and they will have to come out with that thing, whether it is a chicken or whatever. And so people determined that people must pay for something for their health. But during the war, the NGOs did not charge anything, and there were people going to their facilities. So when the government came in and tried to start something like a new fee for service, nobody was going. So the government had to decide that for now, we will not charge any fees in our facilities. So it doesn't mean that you're getting free care. It means somebody is paying for it. Now, right now, we have sent people to different countries to look at their system. I think I have sent 2 teams to Rwanda. I've sent people to Ghana to go and look at what they are doing, and we are talking about doing the same thing like health insurance that they are doing. We're trying to learn from them. But we cannot fool ourselves. Even though we say that you are not paying anything, out-of-pocket spending for health is very high for these people because they have to pay taxi fare to go to the clinic. When you go there, you find out that because of the lack of money, there's no drugs on the shelf, and so they give you a piece of paper to go buy your drugs. Then you have to go back and buy that drug and go. So even though you are saying you're giving free care, what you're doing is actually increasing the out-of-pocket spending for these people. And we are trying to see what we can do to reduce the out-of-pocket spending by following the lead of people who have health insurance programs so that you can go to the facility and don't have to worry that you're going to have to pay. But we haven't reached there yet. We have, our president is endorsing our idea, and we're trying to put it to Parliament so we can go and do something to help the poorest of the poor. Let me say, the poor people are more honorable. If they don't have money, they don't want to go because they don't want to be made ashamed. People who have money go to our facilities and demand for things that they could be paying for, and that's the shame that we have, that those who have are the ones that are not likely to want to pay for what they need.
Thank you very much. I wonder if I could ask you all to look ahead. We've been talking about progress on the MDGs and your experience to date, but you all have challenges that you're facing in your countries. You have successes to build upon. If you had to name the single biggest challenge that you think that you're facing in your country today, the single biggest bottleneck or challenge to further reducing maternal and child mortality, what would you say that that is? And what are you doing about it? I'll start with that easy question with Minister Kambashi. I think it's your turn to go first.
I think the biggest problem that we have as Zambia is staffing of the health workers. Most of the health centers are understaffed. And as government, we are building about 650 health posts across the country. And we need people to work there. We need people to attend to the people that will be visiting these centers. So that is the biggest bottleneck that we have.
Maybe I will go to Minister Al-Hassan next.
Thank you very much. I think the greatest challenge is the implementation of the already existing intervention that we have already started with equity. Human resources is always a big issue for us, especially equitable distribution across the country. Of course, strengthening what have already started that has been yielding a lot of positive results, like the Maternal and Newborn Child Health Week that is happening twice in a year. Of course, this is why we introduce high impact activities like the routine immunization. It is being strengthened through this program, supplementation with vitamin A and etc. and deworming activities. This has been a really high impact program that sustaining them at the speed at which we want to go is really a big issue. So implementation across the country, which is so vast with over 136 million, is a big challenge. That is one thing that we need to focus on and to maintain the speed by which we are going through.
Well, and I understand that this afternoon's session will be about real scale-up.
Exactly.
Perhaps there'll be some interesting lessons there. Minister Gwenegali, looking
Well,
forward.
my biggest problem is inadequate funding for health, because I'm training people that I cannot employ because I don't have the money to employ them. If I have the adequate funding, I will buy the drugs and medical supplies that I need, and I will be able to pay for the people to work because I'm training them. So I'm training people that I cannot employ because I don't have enough funding for it. So the most single important thing for me is inadequate funding for health. If I have it, I can buy the drugs, I can buy the supplies, I can pay the health workers. So that's my biggest problem.
It's the right one.
Yeah.
I'll come back in a moment to what we can all do to work with you on this, but maybe I'll ask Minister Binawaho, as you look ahead, what you see as your
So
greatest challenge.
I think, like my colleagues, one challenge, it's impossible. We have the same challenges.
Yeah.
But if it's tomorrow, tomorrow I will create an army of, not an army, let's say 2,000 ambulance bike for transportation of women for the antenatal clinic and for going delivery. I want to ask this room, abstention of men, who has got a baby and is ready to walk on a hill 5 kilometers in labor to go and deliver? Raise the hand. Nobody. So you need transportation.
Yeah.
So this is something I will do now. Motorbike, very simple thing. She can sit or lie, and we bring the lady from home to a health center. And we will save thousands of lives of children, thousands of lives of mothers.
Yeah.
Transportation. But now, this solves a problem of accessibility, because you can create the best system if the woman cannot go there, even not because of money, just because she cannot walk. We solve the problem of accessibility on top of the human resource, on top of the infrastructure equitably, on top of the money to put fuel in that motorbike.
Thank you much. I think you summarized well the challenges that are all shared. I'm going to ask you all one final question, and but before I do, because I would like to give you all the final word, I just wanted to thank you very much on behalf of all of us for your shared time and your shared wisdom. So I'm going to ask you, I wish we had more time with you, but they keep us moving in programs like this. I think you saw that yesterday and today, that we're keeping a busy schedule here, but hopefully it's full of information and dialogue that's useful for you. So I'd ask you each to think about a parting thought, a little bit based on what you just talked about. We're in the age of social media, you know. Do any of you tweet as part of your job? Okay, well.
Not as part of my job.
Okay.
I do that because I love it.
Oh, good. Well, then I'm going to put you up first and give the ministers a chance to think. We saw in yesterday's meeting, for those of you who are here, we were seeing world leaders around the world tweeting about mothers and children and the quest to end preventable child and maternal deaths. So if any of you could send a message, if you could tweet the people in this audience today, it's an audience full of other country delegations, full of development partners, full of academics, and people who care about global health, who care about the same issues that you do. If you could send them a message about the most important thing that we all need to collectively be focused on, what would your tweet say?
First of all, I will take a photo of all of you, and I will just say, keep it going.
Okay.
Keep it going.
Keep it going.
Keep it
Okay.
going. Okay.
You are an assembly of very good people. It was said yesterday, the world is ready for no unnecessary death, and we are going to make it.
Thank you so much, Minister Binawaho. I will look now to Minister Gwenegali.
Well, you know, right now what we are talking about is what happened after the MDGs, after the 2015. And what we want is those things that we have not achieved, even if we have achieved them, if we don't continue to do the things that we need to do, so then we'll go back through the cracks. Now, you will see that in some of the developed countries where they became relaxed, things like measles is coming in some of those countries. So we have to continue to do the things that we have done to prevent the people from dying. And those things that we have not completed, we want the post-2015 agenda to continue to carry them forward.
Excellent. Thank you, Minister Gwenagale. Minister Kambashi.
Yes, I think what I would say is that to all the people who are here, the audience, I think where we have focused on the mother and child is very important, because without the mother and the child, we wouldn't have the world. I know we are in partnership with the men who are always working with us, but the focus should still remain on the mother and the child. Thank you.
Thank you. Minister Al-Hassan, do you have your tweet ready?
Well, I'm not a tweeting person, but I think I'm getting the urge now to start it immediately. What I would like to have was, I will have a picture of a boy with his mom, of course, probably breastfeeding, and telling the world that we are in this together.
Okay.
That's what I want to do.
So it sounds like we have to keep mothers and children first, be vigilant about what we do, and finish the agenda we've started. We need to keep it going because we're all in this together. Yeah, all right. Well, I'd like to thank each of you for such an energizing and interesting exchange of ideas today. For me personally, it's really been an honor to just be on stage with each of you. And I really would like to thank you, I think on behalf of everybody in the room, for your remarkable commitment and the work that you do every day for the people of your country and for the global health goals we have around the world. So thank you each, Honorable Minister. I think there's going to be a moment or two as we get ready for the next panel, and I'm sure that you've all had a chance to enjoy your lunch, and we might have some now that now that we're finished talking. I believe that you'll be coming up to introduce the next panel, Jim? Okay. We've heard a lot about the importance of quality services and community services today. And I think we're going to be looking at Scale Up this afternoon. Thank you once again, ministers, and we wish you a wonderful afternoon, everyone. Thank you.
Okay, good afternoon, everyone. For those that I haven't had the pleasure to meet, I'm Anita Gibson. I'm the Deputy Director of MCHIP and will be the Deputy Director on the new program. I just wanted to let you know we need a little bit of time just to change things up here. So you've got 5 minutes only. But I know that people tend to get a little bit sleepy after lunch, so you're welcome to kind of stand up and move, but you're not allowed to leave or go very far because we're going to start the next session in about 5 minutes, okay?